Hello, everyone. My name is Kelsey Roof, and this is Hannah Millimet, and we are two fourth-year medical students at Emory University, both applying into obstetrics and gynecology. We want to welcome you all to our maternal health panel featuring Dr. Rudy Gleason, Dr. Marisa Young, and John Cranmer. These three panelists have a wide range of experiences in global maternal health and very much diverse qualifications. We are fortunate to have all of them here with us today. We hope to engage in an informative conversation regarding the importance of collaboration in this field. After our discussions, we will have time at the end of the panel for audience questions. Following our panel, there will be a networking breakout room as well, and we encourage all those who are interested to please join and ask questions in as well. We will now hear from Dr. Rudy Gleason, PhD in bioengineering at Georgia Tech.
Hey guys, hope everybody's doing well. My name is Rudy Gleason. I'm an associate professor at Georgia Tech in the School of Mechanical Engineering, and I also have a primary appointment in the Department of Biomedical Engineering, which is a joint department between Georgia Tech and Emory. And this is just a little snapshot of I've got two pretty diverse aims in my lab. The first aim, really we're studying vascular disease, mechanisms of the development and progression of vascular diseases. It's a pretty active area in my lab. We have part of two R01s. One dealing with mechanisms of the development and progression of atherosclerosis, and the other is development and progression of lymphedema. And sort of at the core is the mechanics of sort of the vascular remodeling involved in those processes. But more relevant to today's discussion, the second aim of my lab is to develop innovative biomedical engineering strategies and solutions to improve maternal and child health outcomes in low resource settings, and maybe more broadly, just global health sort of outcomes in low resource settings. And we work primarily in Ethiopia. And so in terms of maternal care, we've got two active projects right now. The first is developing a tool to assess cephalopelvic disproportion related obstructed labor in Ethiopia. And so CPD is essentially a mismatch between the size of the fetus at delivery and the size of the mother's pelvis, the pelvic passage. And so we're trying to develop a tool to assess women, to assess the risk of a woman during this, and do it sort of timely, so do it well before the onset of labor. In Ethiopia and a lot of places around the world, universal access to emergency cesarean section is just not available. And so if we can identify the most at-risk mothers, then they can be maybe moved to a place where CS is a viable option for delivery. The second maternal project we have ongoing is also early risk assessment of preeclampsia. And so we're really looking at sort of this window of 11 to 14 weeks and developing a safe, affordable, easy to use, and accurate method to assess risk of preeclampsia. Currently, there are methods that show fairly good, predictive capabilities. So Doppler ultrasound, really the key marker that has emerged is the pulsatility index of the blood flow velocity through the uterine artery. Over here on the bottom right is a plot of this pulsatility index. It's a ratio of the peak velocity, centerline velocity at peak systole divided by, say, the mean velocity through the uterine artery, and it's very tightly conserved. The blue triangles are data from papers. I think it's across 40 papers or more. And so there are viable hemodynamic markers out there, but Doppler ultrasound, and there's also circulating biomarkers for predicting risk of preeclampsia in this gestational age. Both of those are high resource solutions. So Doppler ultrasound requires training, requires equipment, requires power, and so does a viable sort of biochemical laboratory. So we're trying to develop innovative solutions, sort of a couple key components. We've developed a hemodynamic model of the maternal vasculature, so how fluid mechanics change, how solid mechanics change, and how vessel geometry changes, how it grows throughout pregnancy. And then we're using this model to identify novel potential markers that are more easily accessible with low resource tools, things like smartwatches and wearable devices. And so that's sort of our second project. This project, the previous project was funded by a Saving Lives at Birth award, and now we got a pending R01 that looks like it's going to get funded. The Preeclampsia project's funded through the National Science Foundation, actually, and that's coming near an end. So we're getting ready in June to submit a new R01 on this project. We're actually getting ready to do some clinical studies on this project as well. I planned on starting last March, but obviously last March was not a good time to start any clinical research in another country. So we're actually looking to ramp this up starting this month, actually. On the neonate side, I'll go through this quickly, but we've got two projects. One, we just actually about a little under a year ago got a great Gates Foundation award to test a wearable device for neonates, particularly high-risk neonates, where it monitors sort of continuously and through a smartphone or a tablet, heart rate, respiratory rate, body temperature, and blood oxygen concentration. And it does this continuously. It sticks on the neonate's chest, sort of like a Band-Aid. And we're testing this, trying to develop this as a device that can be worn for the first 7 days of life. And again, particularly in high-risk neonates. And then finally, this is a project actually born out of a senior design, capstone design project at Georgia Tech that is developing a device to prevent neonatal hypothermia in sort of these critical windows of time where other thermal care interventions like kangaroo care or incubators or things like that are not viable options. Neonatal hypothermia is a big cause of, or at least confounding factor for a lot of neonatal deaths in Ethiopia.
Hi, I'm Marisa Young. I'm an assistant professor of OBGYN here at Emory, and I'm here just to give a brief introduction to myself and the work I've done related to global perioperative care. So I'm very excited to be here and thank the organizers for doing this and for inviting me to speak. So relevant to this work that we're going to talk about today, my background includes that I did an MD PhD program at the University of Illinois in Chicago, which I finished in 2015. My PhD was in epidemiology. And when I finished, I came here to Emory to do an OBGYN residency, which I just completed in 2019 and joined the faculty about a year and a half ago in the generalist division. So my work related to global perioperative care started in 2007 when I joined the MD PhD program, and it started with this person who is Professor Bob Bailey. He is a PhD anthropologist by training, also with a public health background. And when I met him, he had been working more than 20 years and living on and off in Kenya, in Western Kenya, in Kisumu, which is a hamlet just around the corner from Kampala on Lake Victoria, a really beautiful and lovely city. And Professor Bailey was the principal investigator of one of the 3 randomized control trials that showed that male circumcision decreased the risk of heterosexual HIV acquisition by 60%. So these were big landmark trials that came out in 2007. And he decided to stick with it and not just publish this and go on to some other academic project in an ivory tower, but he actually got money from PEPFAR and the Bill and Melinda Gates Foundation to start scaling up adult male circumcision services for HIV prevention in Western Kenya. So he started doing that. And there was one small paragraph in a very large grant that said that they were going to do a pilot study of infant circumcision for HIV prevention. And I was fortunate enough to get to kind of take over that aspect of the work that was embedded in this much larger program of adult male circumcision service provision. So this infant circumcision work started in 2007, and we did a phased approach. So the first phase was just to see whether or not it would be feasible, it would be possible, parents would be willing to have their infants uncircumcised. This is not a procedure that is routinely offered in this part of Kenya, or really in most parts of East and Southern Africa. So circumcision is offered in parts of Kenya, but people do it as a rite of passage procedure at adolescence is when it's traditionally done. And so infant circumcision is not widely known or practiced. We had two OBGYNs for that reason from Chicago, University of Illinois, Chicago, come over, Dr. Irwin and Dr. Nordstrom, and they trained a few providers in the procedure. And so we worked out the logistics of the instrumentation and where and how it could be offered and what our protocols would be and training protocols, and then also some of the counseling aspects for parents and how we would do this, and that we had a favorable outcome from that very small pilot project. It was safe and feasible, and a lot of parents did want the procedure. And so based on that, we scaled up and had them come back over and train trainers. So they trained a few Kenyan clinical providers as trainers of infant circumcision. And then those providers then trained other clinicians in offering the service. We started offering the service at 5 health facilities in and around Kisumu in Western Kenya. And then we recruited parents of infant boys who were actually offered the service, both those who wanted the procedure for their son and those who did not want the procedure. We invited them to participate in a research study to look at decision-making and what people's preferences were and factors associated with wanting or not wanting the procedure, and then also to look at the safety of the procedure. So that was a lot of complex work, and it took many years, although I just talked about it in 2 or 3 minutes. And there were some other projects that we kind of spun off from that. And this is a picture of a grand rounds that Dr. Nordstrom gave at the Provincial General Hospital in Kisumu, the main tertiary referral center in that area. And there was a lot of logistics in terms of talking with people in the public health sector and clinicians, and then obviously also parents. And there were a lot of aspects to this work aside from just teaching people how to do the procedure and then offering the procedure safely. This is some of our study staff, one of our drivers and 2 of the clinicians, the trainers, and one of the 3 research assistants that we had who did this work. So obviously this is complex and there's a lot that could be said about it, but I was, in reflecting about being involved in this work, I have a lot of thoughts. And I'm certainly proud to have been a part of it for many reasons. I think that Professor Bailey's background as an anthropologist really lent a lot of benefits to being a part of this work in terms of making it community focused and having a lot of community engagement in the work. And I believe it was scientifically rigorous, which I'm also proud of. There's lots of aspects of this that I'm proud of. And then I think that there's a lot of complexity and nuance to doing global perioperative care work in maternal and child health. And I think it's important to acknowledge those nuances and complexities and think about them. I don't have the answers, but some of the questions that came up for me a lot when I was doing this work is why it was being led by and conducted, in my case, for me, by non-Kenyans, and why I was being afforded the opportunity to train as an epidemiologist in this way instead of a Kenyan researcher or epidemiology student. And I think I thought a lot about asymmetries in power relationships and acknowledging those and making sure that we were being thoughtful about them, but at the same time challenging the assumption that there was some sort of inherent Western superiority. So I think a lot of people I talked with in the US assumed that I was going over to Kenya as an expert or training other people, when really it was quite the reverse. So I benefited from being trained by brilliant Western and Kenyan scientists, epidemiologists, clinicians, and gained from their expertise. And so I think that that's really important to remember. And then in terms of our specific project, in thinking about the risks of this surgical procedure and whether or not they justified potential societal benefits. And then obviously a very big issue is looking at just donor-funded projects in general and how they're implemented, and what the both direct and indirect effects on the healthcare system are. So, for example, in our project, and the way many of these projects work is we would do trainings and kind of take clinicians out of, Government of Kenya clinicians out of their clinical sites to do these trainings to teach them how to do infant circumcision and what are all of, pay them a per diem and what are all of the kind of implications and effects of doing things in that way. And so these are just a short list. There's lots of things to think about and talk about. And I think it's really interesting and nuanced work. And I hope that we have a great Q&A session. I'm looking forward to that. So thank you so much for having me, and I'll leave it there.
Great. Thank you all for those wonderful introductions to your work and experience. We now want to have an open conversation with you all. We were hoping that the first question you could answer is, could you tell us about your process of forming successful collaborative teams in the field of maternal global health? What are the crucial roles and who fills them? And what difficulties have you found finding good collaborative relationships? We can take turns. We'll start with Dr. Gleason. Sorry.
Sorry, Hannah, I jumped in a little bit late, but I think could you just repeat it real quick to make sure I'm on the right question?
Yeah, just describe your process of forming successful collaborative teams. What are the crucial roles and key players on the field who you're looking for, and how do you go about finding those team members?
Yeah, that's a great question. I think in terms of sort of identifying the team, maybe I'll jump out of order a little bit. For me, we do a lot of work in Ethiopia, as we said early on, and for me, research and collaboration in Ethiopia is very much more relational than I think it is at least in the U.S. and Atlanta. I mean, it's relational here, but it's very much more relational there. And so, I think for me, the key piece to finding the right team members involves a little bit of a relational match, but also a sort of a passion match, finding somebody that has sort of the same passion and desire and sort of collectively coming around the problem that you're addressing. Maybe that's kind of my first thought.
Yeah, that's great. Dr. Young, do you have some input as well?
I agree. I think relationships are really important. I think having a good foundation from the top is also really important. So kind of setting things up in a thoughtful way from the beginning, because that leadership sort of infuses and informs how collaborations are built and team members are selected, and being thoughtful about that. And I think you have to really understand the context of where you're working. There are a lot of relationships that are informed by history and culture and tribe in different places in different ways. And so if you don't know what you're doing, you aren't going to be successful, I guess, in forming good collaborations and finding good team members.
Great. John, can we hear from you as well?
Sure. I think piggybacking off of what both Dr. Young and Dr. Gleason said, one of the critical parts in our team is that before I joined the team, it was first pioneered 11 years ago with an anthropologist, midwife, and from the United States, and a pediatrician from Ethiopia who had a shared interest in community-based strategies to address maternal mortality. So that was the history of how it started. And in that work, there was a keen sensitivity to understanding and following and aligning with community norms and expectations, and partnering with some of the policymakers and the government decision makers so that what scientifically was proposed, what community voice was brought to play, also could be in line with the government and the regional government goals and priorities and programs. So everything was designed to be done in tandem and not in parallel. And I think for our team, that's certainly one of the parts that's critical, because when we go, we might have a scientific idea that we want to test in Amhara, for example, but everything has to be run through the regional and the federal government. And so if we're trying to do our own thing, it's not really going to work. And so it starts by listening, and it starts by building on those relationships that we do have with clinicians, facilities, leadership, regional health bureau focal people, so that work can be done as a cohesive team. So it's not me or Bebe or the region kind of pushing an agenda, but it's really all looking together, say, how can we achieve this particular goal with all of our different strengths and background?
That's great. So would you say it's typical that you would start at the clinician level and then work from there to go up and find local bureaucracy, or better to do it in the reverse order, or which in your experience has worked better in the past?
Well, piggybacking off of that question, I think that one of the approaches that our team uses a lot is like the seed scale model for sustained change. And this is like 100 years of sustained transformation that has occurred globally. And then those findings were distilled down into this model to help guide practice. And one of the core pillars of that seed scale model is building on successes. And so I think that in many ways is our core, that it might be a regional priority, or it might be a graduate student interest, or a principal investigator finds a grant that aligns. It could come from any level of the partnership, but by focusing on the strengths and then focusing on, building cohesive relationship to solve a common problem, it allows us to have the idea originate at any level of that partnership and then grow.
That's great. Could you each speak to some of the barriers you've encountered when forming these successful collaborative relationships, and any life lessons you've learned about ways to prevent this in the future? Could we start with you, Dr. Young?
Sure. I think that, I think the keynote speaker was really excellent this morning and kind of touched on a lot of the nuances of both the, in a lot of aspects of this work. And I think it was nice. One of the things he said is that there are inherent challenges. I mean, in doing anything that's complex and difficult, but particularly when you're adding other variables, like differences in culture and geography and history into the mix, it's hard, and there are inevitably challenges, but you have to recognize that as part of the process and focus on going forward. And so I guess that's not a very specific answer to your question. But I think that there are many common pitfalls. And I think, what I learned early on from my mentor is that you have to, I agree with what he was saying also about starting small.
This is,
and just being a good listener. And
from
so
our
when
intro,
you are the person
we're sort of often on sort of the early stage,
in the beginning, when you don't know anything,
earlier
you start
stage
small and you're a good
innovations.
listener. And I think that's
what I found as a barrier, or at least a limitation of myself
Dr.
early
Gleason,
on
do you have
in
any
this
input on
space
that question?
is trying to be married to a solution rather than being married to trying to solve a problem, And so I think overcoming that barrier is really focusing on the problem, and maybe there's a much simpler and much more elegant solution to that problem than you're thinking about. And I guess just being willing to solve the problem rather than force a square peg into a round hole,
John, do you have any remarks as well?
Sure. I think some of those, in terms of like the pitfalls and trying to avoid them, I have, like all of us, I've certainly had those experiences where you're trying to tap on a door and it doesn't open. and it's a critical door for moving the work forward that from your own perspective, you feel like needs to happen. But I think having an inherent sense of flexibility, I often talk with my graduate students about thinking about their work as gardening. You might have an idea or a professional passion or interest, and then there's a context where there might be an opportunity to do that work. But now you're starting to cultivate that that interest, that project, that research idea, and you plant it and water it and try to create the ideal conditions. and it may grow and thrive, it may flop, it may seed, but you get something along the way. You get lessons, you get reflection, you get new contextual insight, or maybe you get a new idea that then is able to launch. And I think that openness to being surprised and then following that path is one of the things that I think is critical. Because like others have said, you can't necessarily get locked into the solution or the method, but keeping an openness to respond to the circumstances in front of you.
That's great. Thank you. Since this is our maternal health panel, we did want to focus on some subspecialties that, some things that we really need to think about when focusing specifically on maternal health. And I know, Dr. Gleason, you have work in a variety of fields globally. Have you noticed anything that is unique to when you start working with mothers and newborns, and how those relationships develop, or things that we really need to think about?
Is trying to do the best we can to identify the mothers that are at highest risk, so that it's those mothers that are sort of gaining access to the limited resources. So in terms of the challenges or problems that I see just in maternal health sort of globally, or really in Ethiopia, I think that's a key piece to what we've been thinking about, And I had another point, but I lost it already. So maybe we can come back.
Okay. And Dr. Young, you talked a bit in your introduction about bringing the circumcision practice and combating like what the cultural norms already were versus what you're coming in with. Could you talk a little bit more in detail about that and your experience?
Yeah, I think it's interesting. So I would definitely say we were not trying to combat norms, but, and being informed about the way circumcision is traditionally practiced is really important. And I think ultimately, very much influenced the work that we did in the direction we ended up going. And so, like I was saying, circumcision is practiced. So about 80% of Kenyan men are circumcised, and so there are tribes that practice male circumcision traditionally, and other tribes that do not. And the tribes that do it at adolescence as a rite of passage. And so over the years in this work in scaling up male circumcision for HIV prevention, it became very clear that people were very eager to be circumcised generally, and the most acceptable time was at adolescence, because that's how people were used to thinking about the procedure. And so I think that in the beginning, the donors and the big players in public health wanted to circumcise adult men who were at highest risk of acquiring HIV. And so that was the target group. And then we were looking at infant circumcision because we know that it has a favorable safety profile. That's what, it's the way that we practice it in the United States and other places. But ultimately, the people wanted to be circumcised at adolescence. And so the programs that were the most successful, our adult circumcision program was wildly successful. We did a lot of school camps where we would go to schools and they would circumcise a couple hundred boys at a time, and they would do it together. And so that very much informed I think the direction that male circumcision has gone in the country. And I think it's an example of how, understanding the context and the culture and the history really informs being successful in a project.
So you all have various different backgrounds, kind of came to be part of global health and specifically maternal health field in various different ways. So we were wondering if each of you could kind of speak to any guidance you want to give towards someone who's at maybe the same position as you or a different position than you that's interested in pursuing maternal health in the kind of global realm. And John, if we could start with you.
Sure. So I have interest in community-oriented solutions to big population problems, but I also recognize that having the clinical understanding of how clinical care works and what are parameters that you look at the individual level are powerful to help inform what you think about for the population as a whole. So in my own journey, those were the two pillars that I saw as critical. I wanted both the frontline clinician primary caregiver perspective, and I wanted the public health perspective. And so I trained in both of those fields so I could work to bring them together. And I think that one of the things that I often talk to the graduate students about is finding your heart and your passion. So like, what is, like that Martin Luther King talks about your drum major instinct, like what is that thing that's driving you? Because for some people it might be they're driven by clinical excellence or surgical excellence or diagnostic acumen or community-based participatory dialogue methods. Like there could be lots of different approaches. And I'd say, as you think about your path, when you find that thing that most resonates with your heart and your passion, your vision, then you can do it all the time, every day. It could almost be a hobby and not even a job at times. So I think finding that passion and then looking for the opportunities, because it's both about the serendipity of your passion and the opportunity aligning. And so finding people who have like-minded interest, similar passion, resonant expertise, and working together, coming alongside.
Yeah, for
and
sure.
being mentored
As somebody
by them, I think is a
who actually
powerful
was
way
that person,
to,
right? So
to
I
enter
was
into this field,
doing
especially when there aren't
15
quite,
years ago or 10 years
standard
ago,
career paths
and
into
decided,
international global
made a
health,
decision that I wanted to
as
jump
you'll
into
hear
this global health space.
more and more people tell their story.
I think probably the pivotal piece for me
Dr. Gleason, could we hear
was
from
going, was being on the ground in Ethiopia. I just, actually the first time I was there, I just showed up at the hospital and introduced myself I ended up to the dean and just, started interacting with people. And then shortly after that, I ended up doing a sabbatical in Ethiopia. And it was really sort of being on the ground, talking to people where you really get what John was talking about, the context, the understanding of the issues, the challenges. And then as it's your passion, you really sort of explore and hopefully identify places where you meet a critical need in the process of helping to try to solve these problems.
Great. And Dr. Young?
Yeah, I think that it's important to, like when starting out, making sure that you're working with, a team that is thoughtful and has a good track record and a good foundation. And then I guess like taking your time, it takes time to do this and to become acquainted. And it's probably not the kind of thing that like lends itself well to just something short or temporary and permanent.
So, Dr. Gleason, we have a question from the audience for you. So, how can these projects of the early risk assessment of CPD and preeclampsia and neonatal devices be beneficial to other neighboring countries like Somalia that has a border with Ethiopia, for example, where maternal and infant mortality rate is very high?
And this doesn't necessarily work
for example,
Somalia,
specifically,
but I've actually
the
gotten to
ratio
know John a little
of
bit over
Somalian
the
and maternal
last
mortality is
years.
around
I'm sort of
832 to
I'm sort of a gadget
100,000,
guy,
while infant mortality is
and
around
I'm trying to
70
learn how
1,000.
to test and develop gadgets for low resource settings. But it's really bringing together partnerships with a much broader community, people that are great at, okay, now we can translate this thing, have a broader reach for these things. So, our sort of next steps for the CPD project are to actually spread across Ethiopia, and I'd love to figure out ways to get to Somalia, and sort of now we're getting ready to start a nationwide study, and from those nationwide sites we can start to spread the reach of these interventions. The challenge with our innovations is they're still really not tested. They're still not ready for prime time, so to speak. They're still not really validated in the clinic. So we don't want to press too early for something that's not really ready for the clinic yet. So.
And then Dr. Young, as two future OBGYNs ourselves, we were kind of wondering, Atlanta and Georgia specifically kind of has a higher rate of maternal mortality. We were wondering if you could kind of touch on how your work in global health kind of helps you think about like how you as a practitioner here in Georgia specifically can kind of help figure out what's the main reason behind this high maternal mortality rate.
Ooh, that's a really good question and complicated. I do think that the time that I spent in Kenya has very much informed like the way that I approach patient care and think about caring for people, for moms and babies. And I think that, you know, again, a lot of it is just being aware that people come from different cultural contexts and different experiences, and you have to take the time to listen to people and hear what they're saying. And I think that the reasons for our absolutely abysmal maternal mortality rate here in Georgia are incredibly complex, and there's a lot of people in our department who are part of looking, you know, studying why and trying to find solutions to improve outcomes for women here in Georgia. But I think a big part of it is sitting down and actually listening to patients. And so I think that the work that I did really did help me do that and have that approach when I take care of patients.
Thanks. John, could you talk about your experience at Emory and fostering mentorship relationships with students both in the nursing school and the School of Public Health, and how you can really help get more people involved in learning about this field? Oh, you might be muted.
Yes, thank you. Absolutely. That's a really exciting part of the work because as we've talked about with these complex challenges, there's no one single path to a sustainable solution. And so, you know, if we go back to our geometry days in, you know, 9th, 10th, or 11th grade of high school and have to work on understanding the relationship between polygons and circles, you know, we know that the more sides you add to the polygon, the closer and closer you get to a circle. So a triangle is quite far from a circle, a square is a little bit closer, a pentagon's even closer, and so forth. And I think in global health, the same principle applies. If you conceptualize this circle as like a solution or the best solution, it takes multiple lenses and multiple components. And so one of my philosophies is that you have to have transdisciplinary intersectoral teams. And so, you know, I have clinicians who I work with. I have public health professionals. I've been working with Dr. Gleason's team, and we have some engineering strategies and some system people and some policy people. And we work together in different configurations for different projects based on, you know, funding and graduate school timelines and other things. But at the end of the day, the more interdisciplinary we can be, the better it is for the work. And so I love that. I look for that interdisciplinary nature as mentees are joining our team.
Thank you so much. We still have the chat open for audience Q&A. If you guys have any questions, please post
First of all,
them.
Thanks
and if not, we would just like for each of you, if you have any closing remarks or something you really wanted to talk about today that we haven't touched on
this idea
yet,
of
please
what
feel
John
free
just
to
raised
share.
about
We can start with whoever
nature
feels like they're ready.
of this work specifically, an interdisciplinary.
Do you want to go, Dr. Gleason? Do you have anything else to add?
With sort of the cross-cultural nature of it, makes us get some sort of unique and interesting challenges, but also probably for me the most fulfilling part of it is trying to figure all that stuff out together and learn from people from different cultures and different disciplines. Man, it's such a learning experience for me personally. So I've just loved it, and just want to encourage people to jump on board and to try to figure this out. As John said, I think it's, you know, we are still a little bit undefined in who we are and what we're trying to do, you know, but I think there's a huge opportunity out there to work together, to collaborate, to have a really amazing impact.
Great, thank you. John, would you like to add some comments?
Sure. I think, you know, as we're in the process of, you know, building skills and doing graduate training, undergraduate training in fields of interest, I just encourage us to think about how to start small, you know, because sometimes we have a big passion or a big drive, and we arguably defensively want to conquer the world or conquer that problem. And I think that's part of the drum major instinct that we should listen to. But at the same time, it could be frustrating if you see the magnitude of complexity and you're like, well, I can't do anything. And so I think that's where the start small and build strategic alliance is critical, because we have in the mentorship group that I'm working with, we have everything from postdoc fellows to secondary students that are involved. And so I'd say we can start anywhere. We can find people who are doing the kinds of things we want to and just see what type of learning opportunity is there. How could we partner and join a team and bring the skills and interests that we have to make a contribution? So find some mentors, partners, and even near peer mentors for secondary students to work with, college students, and college students to work with graduate students. I think there's so many opportunities where we can learn from our near peer group.
Yeah, that's great advice. Thank you. Dr. Young, any closing remarks?
Just to say, I agree with what has been said. I think that those are great comments, and I also appreciate the opportunity to be here. I think it's really such a privilege to work in this field of maternal health, and caring for women and babies is such a privilege, and I think it attracts people who are really passionate about that. So it's great to be here to talk about it with everyone.
We want to thank the three of you for coming today and speaking with all of us, and also everyone who is attending our panel today. We sincerely enjoyed this discussion. I myself learned a lot. And we want to thank you all for joining us and sharing each one of your unique experiences and paths towards, such a successful kind of career in global health. So we hope you all, the attendees, will join us. Now we're going to move on to the networking phase, and we're happy to have more of a discussion there about some specifics. But thank you all so much.
Thank you.
Great, thank you.
Hello to my friends who so generously gave your time and efforts to join this panel. I am overwhelmed, and thank you so much. I have some questions for all of you. My first comment, however, is I always learn how to do things better at home from how my colleagues overseas do things for their patients. So thank you again. Dr. Fagan, I have to address the masterful job that you've taken, the enormous job that you've taken on to point out that all of our fancy cancer treatment guidelines simply do not apply to many settings around the world. And thank you for doing that. That also has great value for middle-income countries as well, or in rural settings in the United States. But can you briefly again describe the process for how you modified those guidelines? Did you use a consensus, surveys? How did you do that? I'm not sure Dr. Fagan is still on. Let's see. If not, I'm changing my next question to Dr. Macharia. I'm so curious about how, on the ground, what are some of the best things you have at AIC Kajabe for your head and neck cancer patients? What are some of your best assets?
Thank you for this opportunity. I'd say Kajabe has been a site of training of both surgeons and anesthetists. So we're able to have fairly high standards as far as surgical services are concerned. Right now as well, I work with a colleague. He is an expat from the US. His name is Dr. David Nolan. He is an otolaryngologist that's also done a fellowship in facial plastic surgery. So for our patients in Kajabe, we're privileged that we're able to offer fairly timely, decent surgeries as well as reconstructive options where possible. But that may not be the same for all my colleagues. But yeah, it's been a pleasure to work here. Yeah, and those are our assets. Thanks.
What are some of the challenges? What would you like to see? What deficits would you like to see fixed at Kajabe?
Well, actually, it's even a bit more global than Kajabe, and I think what has been pointed out earlier is elucidates it quite well. We are definitely struggling to keep up with the numbers. The number of patients that need urgent surgeries, especially cancer surgeries, are quite big, and yeah, just for the two of us, that becomes difficult to keep up, and so we're constantly. Every week is a battle to try and clear out the backlog, and so the idea of training more head and neck surgeons for the continent, we definitely see that at Kajabe and in the country. We need more. We definitely need a lot more people that can offer a good, safe surgery for head and neck cancer patients.
Thank you, Dr. Macharia. Dr. Koch, I am so in awe of the work that you've done, and thank you so much. I'm honored that you joined us. When you have exchanges, which I understand you do have some exchanges between Hopkins and Cameroon, what is the most valuable thing that an observer from another country can get from coming to a high-income setting? What do you think is the most valuable thing that they can glean?
Well, the fellows from our African training program have come to the U.S. for a month. And during that month, I think they get exposure to a multidisciplinary oncology team of the sort that we're all used to in the U.S., but is often not available. We saw the slides about how few places have radiation oncology, and that's starting to improve in the cities particularly, but isn't available for everybody. So I think to see how the pieces fit together and get an ideal sense of how that might be built in home country, what the nature of those collegial interactions could be, that's quite helpful. Obviously, the exposure to world-class surgical options, and there are things that people have read about but not seen, robotic surgery, laser surgery. A little exposure to that, I think, opens eyes. And it's my firm expectation that our African colleagues, especially again in the cities, will be catching up technically during their career lifetime. Free flaps and maybe even robotic surgery will eventually be available in country. So being leaders, thought leaders for home country requires having your eyes opened. Of course, the fellows that go to Cape Town see that in a developed world setting there. Then I guess the last thing is an entrance into the societal networking that's available. I know Dr. Macharia and the others have gone to one of our national or international meetings and been able to meet people that maybe their textbook name is recognized, but now they can put a face to that and begin to interact. And that's, I think, quite beneficial to in both directions for us to build those collegial interactions.
You mentioned that you have, in 2017-18, you had 12 faculty members come to Cameroon to help out. What were the challenges for some of those faculty members? And how would you recommend future faculty to contribute to Cameroon's training?
Oh, I mean, I think anybody that's done a short-term visit internationally knows that the benefits outweigh the challenges for the vast majority of cases and for people. But the challenges are logistical, travel sorts of things. Different countries have different regulations. This is part of the problem we've had in this COVID year, is a regulatory problem as well as a safety problem and regulatory problems at home. The travel is daunting. It takes 3 days to get to our site, and you're jet lagged when you get there. And about the time you've gotten used to the new time zone, you turn around and go back. The challenge of working in an environment without the safety and technological things that you're used to Cameroon, our program does have a CT scanner, but no MRI, certainly no PET scanning. So you learn, if you don't already have that capability, you learn how to do things the way that our professional fathers and grandfathers did, a lot of which is the same wisdom that we have now. It's just you have to recall to mind what you can learn from a good physical exam. You don't need to have image guidance on your CT scan to do sinus surgery if you know the three-dimensional inside of the nose, for example. So those things I think are stretching and of great benefit both to the faculty and to the residents who've been able to come. And I would say everybody has had a great experience if they take the plunge and go and do it.
Thank you. My observation likewise is the either trainee or U.S. high-income faculty member who's had the opportunity to contribute in that way, they actually come home and they're a much more thoughtful user of resources, which is desperately needed on the high-income countryside. And likewise, the ability to make good, sound clinical judgment without all that high-tech stuff is a challenge to keep. And so that is one of the huge benefits. I see that we are just at the end of our time, and I must thank you again. I am so honored that all three of you agreed to give up your time and expertise. I learned so much, and I always do when I interact with you. And Dr. Macharia, I look forward to every month. The Head and Neck Tumor Board is unbelievably good and a learning experience. And I bring my residents into the room whenever I can. My Emory residents benefit tremendously from your experience, your presentation. So thank you. And
thank you so much.
Of course.